A routine doctor visit can cost about $100 more. The reason can be a hospital billing status patients never see. It can add a facility charge even when the medical service stays the same. That charge has a name and a specific set of rules behind it. Here's how one visit can turn into two separate charges. For decades, a small clinic sent one charge: the doctor's work and nothing else. A hospital-owned clinic can qualify to bill as a hospital outpatient department. That's a clinic billed as part of the hospital, under 42 CFR 413.65. It can then send two separate claims, a professional claim and a facility claim. The professional claim pays the doctor for the exam. The facility claim covers overhead the clinic can't bill alone: building, equipment, staff. Qualifying takes more than a change in ownership. Specific Medicare requirements must be met before a location can bill this way. That federal rule technically applies to Medicare, not commercial insurance. But commercially insured patients see a similar pattern. Real claims data shows separate physician and facility billing for the same visit. What a commercial insurer pays depends on its contract with the hospital system. It also depends on whatever state law applies. There's no single nationwide rule for commercial plans, the way there is for Medicare. On your bill, it can show up as its own line. Sometimes it's labeled a facility charge. Sometimes it's a clinic visit fee. That charge is real, but it isn't guaranteed for every patient. What you pay depends on your insurance plan, your deductible, and your coinsurance. Coinsurance is the share of the bill you still owe after that. It also depends on whether your plan covers a facility charge at all. Hospitals don't call this a trick. The facility fee is meant to cover overhead the clinic can't afford alone. That includes equipment and staff. Prices for medical care can rise for many reasons: inflation, new equipment, higher demand. This one is different. It depends on where a visit is billed from, not on the care itself. Meet Maria, 36, insured through her job, like most working adults. She'd seen the same doctor at the same clinic for years. Then one visit came with a new facility charge. Her care hadn't changed. Her clinic had recently started billing as a hospital outpatient department. Clinics like Maria's are being bought by hospital systems at a fast pace. Not every acquisition changes how a clinic bills. But when a location does qualify, this is the shift patients can see. This isn't limited to office visits. Imaging, infusions, even some telehealth calls can carry the same fee. This isn't a story about one clinic or one hospital. It's a story about a billing status reshaping healthcare nationwide. And it's documented in federal filings, in national data, in real billing records. Here is the documentation, starting with how common this has become. In September 2025, the Government Accountability Office studied physician-hospital consolidation nationwide. It found 47% of doctors affiliated with a hospital system in 2024. In 2012, that share was under 30%. Not every acquisition changes how a visit is billed, but it's the trend behind why more visits now qualify as hospital outpatient care. A national database of real commercial insurance claims puts a number on it. For primary care visits, the total price averaged $116 in an independent physician's office. In a hospital-owned outpatient setting, the same kind of visit averaged $217. That's a difference of about $101, roughly $100 higher on average. HCCI attributes about $114 of that outpatient price to the facility charge itself. That's specific to primary care and pediatric wellness visits, not every appointment. It's drawn from real 2022 claims for people under 65 with job-based insurance. It reflects a total price, not a sticker price, and not Medicare. That gap is not a guarantee of what you'll personally pay. Your actual out-of-pocket cost still depends on your plan. Facility fees like this are rare in percentage terms. They show up in about 0.5% of primary care visits in the data. That's still roughly 685,000 visits a year. Pediatric wellness visits show a similar, slightly lower rate. The gap shows up beyond office visits too. One 2023 analysis of Texas Blue Cross Blue Shield claims looked at colonoscopies. At a hospital-owned site, the facility charge alone averaged $1,607. At an independent surgery center, the same facility charge averaged $930. The doctor's own charge was the same in both settings, $159. Combined, the total price was $1,766 at the hospital site. That's 38% higher than the $1,089 total at the surgery center. Even some Medicare telehealth visits can carry a facility charge. It applies only to eligible originating sites that host the patient for the call. For 2026, that charge is set at $31.85. A different kind of proof comes from a single patient, a retiree in Ohio. Her insurance was Medicare Advantage, a privately run version of Medicare. That's a different population than the commercial insurance figures above. She received the same steroid injection from the same doctor. The clinic had moved to a hospital-based location one floor away. Before, her visit cost about $30. After the reclassification, her total charge was $1,394, most of it a facility charge. That single line item came to $1,262. She paid $354.68 out of pocket. That's more than 10 times her old copay. This case was reported by KFF Health News in its Bill of the Month series. It also aired on NPR. To protect her privacy, we're calling her only a retiree in Ohio. Her case and the commercial insurance figures above are two separate data points, different populations, but a similar underlying pattern. The Medicare version of this rule has been partly reformed. A 2015 federal law reduced facility charges at newer, off-campus locations, but roughly 2/3 of hospital-owned clinic visits still happen on the main campus. That 2015 reform only applies to certain locations. Offices that opened off-campus after November 2015 get the lower rate. Ones that opened earlier or sit on the main campus do not. Those main campus visits are still billed at the full higher rate. Regulators later cut the off-campus rate further to about 40%. Hospitals sued to stop it in a case called American Hospital Association versus Azar. A federal appeals court sided with the government in 2020. The Supreme Court declined to hear a further appeal in 2021. A federal advisory board, MedPAC, has proposed broader reform since 2012. Its June 2023 report recommended aligning rates for 66 specific services. Congress has not passed it. It remains a proposal, not law. By last count, 9 states ban facility charges outright for certain visits or locations. 19 states have passed at least some related law, including simple disclosure rules. Most states do not have a broad facility fee ban. Connecticut was the first state to act, back in 2015. So here is what you actually know now. The price of a doctor's visit was never only about your health. It can also depend on how that visit gets billed. About $100 more in total price for the same kind of visit on average. One retiree faced a $1,394 total charge and paid $354.68 herself. Her earlier visits had cost her about $30. Maria's checkup never changed. Her doctor never changed. What changed was how her clinic was allowed to bill. There's no single rule banning this everywhere. Medicare has partial protection, but only for some visits. It doesn't cover care delivered on a hospital's main campus at all. Commercial insurance isn't covered by that federal rule at all. Facility fee protections for commercial plans largely depend on state law. They also depend on the insurer's contract with the provider. That gap isn't hidden. It's written into billing codes and contracts most patients never read. That gap didn't happen by accident. It's the result of payment rules most patients never see. This is not the only price shaped by where your care is billed from. It is simply one of the clearest to trace: a federal rule, real claims data, and one real case all point the same way. For a household stretching every paycheck, a surprise facility fee is not a rounding error. It's real money, for care that never changed at all. You cannot see a clinic's billing status from the waiting room chair, but now you know it exists, and you know why the same visit can cost differently than it did last year. None of this means avoiding care. It means recognizing what a second charge on a bill actually represents. That is the facility fee trap, not one hidden fee. A billing status, working as the rules intend. A change in billing status can add a charge you never expected. Ask what else might be changing without your knowledge, quietly behind the paperwork. Billing isn't the only place that happens. We've already traced a similar pattern in how insurers decide what gets covered. Watch that one next.